Now I'm going to introduce you the program and our speakers. And again, it's really pleasure to have you with us, and thank you for your time joining the session. Today's topic offers fresh and forward-looking perspective on the early detection and evaluation of chronic kidney disease, with a particular focus on the innovative and clinical promising biomarker uromodulin. Before we begin, allow me to introduce our guests, Professor David Fridecký, Dr. Lenka Vasilova, and Mr. Patrik Hrubčík. Professor Fridecký is a highly respected expert in clinical biochemistry, metabolomics, and mass spectrometry. His career has been dedicated to scientific research and the introduction of innovative diagnostic approaches into routine clinical practice. In 2022, he was appointed professor in medical chemistry and biochemistry. Since 2002, he has been affiliated with the Department of Clinical Biochemistry at the University Hospital Olomouc, where he has served as head of department since 2023. He also led the clinical mass spectrometry group in the Faculty Hospital Medicine, Palacký University in Olomouc, Czech Republic. Professor is active member of the committee of the Czech Society for Clinical Biochemistry, the lipidomics section, the Czech Mass Spectrometry Society, and serves as a several expert advisory boards. Dr. Vasilova serves as a doctor at the Department of Clinical Biochemistry at the University Hospital Olomouc. She graduated from the Faculty of Medicine at Pavol Josef Šafárik University in Košice, Slovakia in 2013. She began her medical career in 2013 at the Department of Anesthesiology and Resuscitation at Prostějov Hospital, and from 2015 continued at the Department of Anesthesiology, Resuscitation and Intensive Medicine at the University Hospital Olomouc in Czech Republic. Since 2024, she is working in the field of clinical biochemistry, where she is currently preparing for her specialist certification. And Mr. Pavel Hrubčík graduated in biochemistry from Palacký University in Olomouc, Czech Republic. He is currently affiliated with the Department of Clinical Biochemistry at the University Hospital Olomouc, and is undergoing professional training to obtain certification in clinical biochemistry. Now I'm going to speak about the program. Webinar program is divided to 5 parts. Introduction to chronic kidney disease, led by Dr. Vasilova. Uromodulin and its biological function, Patrik Hrubčík. Uromodulin as chronic kidney disease is led by Professor Fridecký. Clinical case studies will be introduced by Dr. Vasilova again, and last session will be dedicated to question and answers. And in the case you would like to ask question during the webinar, please feel free to write your question in the chat, and we will address all questions at the end of the program. It is my pleasure to pass the word to speakers. And again, thank you very much. Thank you very much being with us and for your patience. So, Dr. Vasilova, you can start. Thank you very much.
So, to continue, today I would like to give a brief introduction into the topic and talk about chronic kidney disease. Okay. Chronic kidney diseases are defined as abnormalities of either structure or function of kidneys that are present for at least 3 months and have implications for health. Those abnormalities we can see by different markers. Here on the slide we see a table that I borrowed from newest KDIGO guidelines, and we see listed some markers, for example, of kidney damage. We can see a presentation of albuminuria, or sometimes we see urine sediment changes such as leukocyturia, erythrocyturia, or presence of granular casts. Sometimes we see electrolyte disorders or acid-base changes. From imaging techniques, we can see smaller kidneys or reduced cortical thickness, polycystic kidneys, or hydronephrosis that was induced by obstruction. As to the function part, even though glomerular filtration rate is considered as marker of excretory function of kidneys, it's widely accepted that the best overall index for kidney function is glomerular filtration rate, and other kidney functions decline in parallel with glomerular filtration rate in CKD. So it pretty accurately is able to estimate kidney function. About kidney disease. Okay. Here we see epidemiology. We should talk about it because, as we see here, a lot of people are affected. In year 2019, CKD was responsible for 41.5 million of DALYs. DALY is a number we use to estimate global burden of disease on the population, and DALY is combination of life years that are lost to the disease and years that are lived with disease or with disability. In 2019, CKD was responsible for 1.43 million of deaths worldwide. It not only poses this burden in form of life years lost, but it also poses huge economic burden, and this burden increases with disease progression. Here on graph, we can see that this burden is not equally distributed throughout the world, and we see that the countries with lower socio-demographic index carry higher burden. They are more affected by chronic kidney disease. When we are describing CKD, we use recommended nomenclature. We should mention the cause of the disease because it's important to know for next management and treatment of patient, also to know the prognosis of patient. Then we talk about glomerular filtration rate and rate of albuminuria. This heat map that you can see now is probably very well known. This heat map represents prognosis of patients with chronic kidney disease, their overall morbidity and mortality prognosis. You see that with worsening or decline of kidney function, decline of glomerular filtration rate, and increase of albuminuria, the prognosis for the patient gets worse. Not only overall prognosis, but patients with CKD are at higher risk of other comorbidities or other complications compared to population with normal kidney functions. For example, you can see that they are at higher risk of overall cardiovascular mortality or higher risk of myocardial infarction, stroke, heart failure, or need for hospitalization from different causes. Also, patients with higher stages of CKD are at higher risk of need for renal replacement therapy. Most common complications of CKD we see in patients are fluid overload. Kidneys are not able to excrete as much fluids as they should, and fluids stay in circulatory system. On the other hand, at the same time, kidneys have changes in arterioles, and kidneys perceive hypoperfusion of glomerulus as hypovolemia or hypotension. And even though body has enough fluids, they still perceive it as if they don't have enough and try to retain even more fluid. So this leads to even higher fluid overload in patients. That could lead to hypertension or to congestion. Other complications and really common complications in those patients are, for example, dyslipidemia. It's because there is decrease in lipid-lowering enzyme activity. There is increase in lipoprotein production in liver, mostly because when people with CKD have albuminuria, they lose a lot of proteins, they have decreased oncotic pressure, and liver tries to substitute that with lipoproteins. There's a decrease in LDL clearance. And this dyslipidemia then aids to the cardiovascular comorbidities and complications. People with CKD suffer from anemia. That could be either because of blood loss, hematuria, or most commonly, it's because of decreased production of erythrocytes. Kidneys react to hypoxia by producing erythropoietin. Erythropoietin stimulates bone marrow to produce red blood cells. But if we don't have enough of functional kidney tissue, kidneys are not able to produce as much erythropoietin as needed, which leads to normocytic, normochromic anemia most times. Another complication that has potential to significantly decrease quality of life of our patient is mineral bone disorder, because there is disorder of mineral metabolism involving calcium, phosphate, and metabolism part hormone, vitamin D. This all leads to bone disease. Patients suffer from fractures, pain, impaired mobility, and disability. Patients mostly in higher stages suffer from malnutrition, hypoalbuminemia. They are prone to development of metabolic acidosis or abnormalities. So who is at risk of developing chronic kidney disease? The most prevalent cause is diabetes. Diabetes is responsible for 30 to 40% of all CKD cases. It's very important to know, because once you have a patient with diabetes, you know that you should probably screen him and do regular tests. For example, at the time of diagnosis of type 2 diabetes, patients should have their kidney functions tested. If it's type 1 diabetes, it's recommended to screen patient within 5 years from diagnosis. Another second most prevalent cause of CKD is hypertension. It makes up for about 20% of all cases. Again, if we have patients that are treated with hypertension, it's the best to screen them regularly to check their renal functions. Then patients with glomerulonephritis are at risk of developing CKD, or people that had acute kidney injury, and the more acute kidney injury events a patient had, the higher risk of chronic kidney disease it poses to him. Patients with chronic inflammatory conditions such as vasculitis or drug-induced nephrotoxicity, on a daily basis we use a lot of imaging techniques that use contrast, or we administer nephrotoxic drugs, and we should monitor renal functions in those patients. Sometimes the cause is genetic, for example, Alport syndrome, which we will discuss in clinical cases later. Sometimes there are genitourinary disorders like kidney calculi. Here we see algorithm that I borrowed from newest KDIGO CKD guidelines. Here we can see the recommendation that if we know that patient is at risk of developing chronic kidney disease, if he has hypertension or diabetes, it's best to test him to measure his glomerular filtration rate and estimate albuminuria, and test these functions regularly. If tests come up normal, then based on the characteristic of risk and risk of progression, we should test him within some time in the future. If it's abnormal, we should decide if it's acute kidney injury or chronic kidney disease. If it's acute kidney injury, we should proceed based on recommendations for treatment of acute kidney injury. If it's chronic and we have evidence of chronicity, then we should decide which tests are best for him to establish his renal functions, to be able to stage CKD, to establish underlying cause, to estimate risk of progression, and to start targeted treatment of our patients. How can we evaluate kidney functions? Well, kidneys have multiple functions. We know that it's excretory, endocrine, metabolic functions. But as I mentioned earlier, it's overall agreed that glomerular filtration rate is pretty accurate index of kidney functions, and other functions follow changes in glomerular filtration rate. We could use methods that estimate glomerular filtration rate or measure. Every day we use the estimate glomerular filtration rate. Nowadays, it's not recommended to use just serum creatinine concentration. It is not very accurate in looking at kidney functions. Nowadays, we use creatinine-based equations for estimation of glomerular filtration rate. Sometimes there are factors that influence the amount of creatinine in serum and could be sources of error in this estimation. So sometimes it might be wise to use also cystatin C, so equation based on creatinine and cystatin C. And in many times this is enough. There are certain cases where even this combination might be not accurate because cystatin also has some situations in which it's not very accurate, and there are some clinical scenarios in which we really need accurate estimation of glomerular filtration rate. For example, if there is a patient that needs transplantation of kidneys and other organ, we really need to know how kidneys are working. So then it might be recommended to use measured glomerular filtration rate. Then there's used exogenous filtration markers. Problem with this method is that it's costly, it takes a lot of time, it's complicated. Not all laboratories are able to do this, so this is not widely available. When we are talking about estimation of glomerular filtration rate, as I mentioned, we use creatinine or cystatin. Creatinine has a lot of pros. It's low cost, it's available widely. Laboratories and clinicians have experience in interpreting results, but it has also a lot of non-glomerular filtration rate related determinants, which really affect the accuracy of this test. It's really dependent on muscle mass, it's dependent on sex, age, diet. If somebody intakes a lot of cooked meat, his serum creatinine concentration will be higher. Catabolic states are problematic because patients in sepsis, traumatic patients, shock patients, they really quickly lose muscle mass, and in those scenarios, creatinine might not be very accurate. Creatinine is also not able to react to acute changes in kidney functions. It has sort of lag time. The delay is around 2 to 3 days. It's also dependent on distribution volume in patient. Another problem is that some medications that we administer to our patients interferes with enzymatic photometric methods. And as you see here, many of those medications are daily used, and especially in scenarios of ICU, we daily use catecholamines like norepinephrine to treat hypotension, or many patients have metamizole for treatment of pain, and they intake it few times a day. So there are some limits in using creatinine and creatinine-based glomerular filtration rate estimation. As to the cystatin C, it's a very good marker, has its pros and cons. It's stable through the day. It's better able to indicate even small changes in glomerular filtration rate. It's not so dependent on muscle mass. And it's better able or quickly able to react to changes in glomerular filtration rate. Problem with creatinine is that it's influenced by corticotherapy. Administration of corticotherapy increases levels of cystatin C, and all conditions that are characterized by increased cell activity also increase serum concentrations of cystatin. So tumors, inflammation, all those conditions might not be accurate. The cystatin C might not be really accurate in those conditions. Also, untreated or not properly treated hyper or hypothyroidism might influence cystatin C levels. It's also more costly than creatinine. Here we see algorithm that is recommended for approach how to evaluate glomerular filtration in our patients. For initial screening and testing, glomerular filtration rate based on creatinine is good and enough. If there are not any limiting factors or sources of inaccuracy, we can stick with that. If this test might be inaccurate, we might need to use cystatin C, and then combination equation with creatinine and cystatin is recommended. If there are not any limiting factors that would influence accuracy, we use this equation. If there is some limits to our possibility of errors, or in clinical settings we need more accurate estimation of glomerular filtration rate, we might consider measuring glomerular filtration rate. But here clinicians should know that only to do it if it will bring anything to the table, if they will change their decision, or if it brings any new information for their patient or for management of their patient. So to conclude, chronic kidney disease increases overall morbidity, mortality, severely affects quality of patients' life. Nowadays, for staging, diagnosing, and assessing risk for chronic kidney disease, we use glomerular filtration rate and albuminuria, but as we were discussing, it has some limits, and for measurement, it's not widely available, time-consuming, and high cost. Also, these markers, they reflect glomerular functions, but they offer very limited insight into tubular interstitial damage. So there is space for developing new markers that would bring new information as to the tubular function and to help early diagnosis, which is very important for early treatment and prevention of progression of chronic kidney disease into the higher stages, all for better outcomes for our patients. Thank you very much.
So if I can start, good afternoon, everyone. Thank you for the introduction, dear colleagues and guests joining us online. My name is Patrick Rubčík, and following the excellent lecture by Dr. Vasilova, I would like to share with you today the fascinating story about a protein, that plays a key role in our topic, and the name of this protein is uromodulin. So if you stay with me until the end, we'll explore its chemistry, biology, physiology, and as with most biomolecules, also its darker side, the role it plays in disease processes. So let's dive in. Let's start with the basics. Uromodulin is a glycoprotein. That's very important, as you'll soon see. It is produced exclusively in kidneys. This gives it a major advantage compared to other markers of kidney function, which often rely on molecules made elsewhere in the body. Uromodulin, however, reflects kidney activity directly. It's actually the most abundant protein in human urine. You excrete up to 50 milligrams every day without realizing it. From a clinical biochemistry perspective, it shows great promise as a marker of kidney health. So it's a bit of a modest hero. It makes many vital things, yet remains relatively unknown. When I was in university, our teachers used to say us that every good lecture should begin with a bit of history. So I will follow their example because for me the history of Uromodulin is both interesting and sometimes amusing. So here are the four milestones. In 1873, Italian Dr. Carlo Rovida first described a protein in urine that formed tubular patterns under the microscope. Then in 1950, Thum and Horsfall isolated this protein from the urine and partially described it and naming it of the Thum Horsfall protein. In 1985, Andrew Muchmore and John Decker found protein in the urine of pregnant women with immunosuppressive properties and called it uromodulin. Finally, in 1987, Diane Panica and her team confirmed that uromodulin and the Thum Horsfall protein were in fact the same molecule. So from a waste molecule, uromodulin became a scientific star, even featured in Nature. Chemically speaking, uromodulin is a glycoprotein encoded by a gene on the short arm of chromosome 16. It undergoes extensive co- and post-translational modifications. The most importantly of these modifications is glycosylation, which is essential for its function. Its molecular weight ranges 80 to 90 kilodalton, with around 30% of that coming from carbohydrates. Uromodulin is rich in cysteine, 48 out of its 640 amino acids, forming 24 disulfide bonds. These stabilize the structure of the glycoprotein. Additional modifications like sialylation and sulfation give the molecule a strong negative charge, while fucosylation also plays a structural role. Structurally, uromodulin is dominated by beta sheet with almost no alpha helices. This diagram shows uromodulin's domain, structure domains. Each has its purpose. The most important are the D10C domain and domain external hydrophobic region. The D10C domain, rich in cysteines, contain half of all disulfide bonds in the protein. It helps connect monomers during polymerization in urine and can bind uropathogens and certain ions. The external hydrophobic region, on the other hand, prevent premature polymerization and anchors uromodulin to the cell membrane via a GPI anchor. Just before this region is the cleavage site for the serine protease hepsin, which released uromodulin from the membrane into urine. Biosynthesis of uromodulin. Uromodulin is produced only in the kidneys, specifically by tubular cells in the thick ascending limb of Henle's loop and the early distal tubule. On the apical side of the tubular cell, it's transported through the endoplasmatic reticulum and Golgi apparatus to the membrane, where it attaches via the GPI anchor. When hepcin reacts, it's released into urine where it polymerizes into fibrillar networks. On the basolateral side, it's secreted into interstitium and bloodstream, where it remains as monomer or dimer, since no cleavage occurs there. But we still don't know much about this pathway of uromodulin production. Now let's look at uromodulin's key physiological function. The first is antimicrobial defense. When anchored to the tubular cell membranes, it prevents bacteria from reaching the cell surface. In urine, polymerized form traps and aggregates uropathogens. This process depends on glycosylation. The carbohydrates part of uromodulin reacts with the bacterial FIMH protein on fimbriae, helping flush bacteria out of the body. Another important function is inhibition of crystal formation. Thanks to its glycosylation, uromodulin carries a strong negative charge, mainly due to sialic acid residues and sulfatation. This allows it to bind positively charged ion like calcium, preventing the crystallization of calcium oxalate or phosphate, because they are key components of kidney stones. Uromodulin also helps regulate the immune response. It reacts various receptors, sometimes activating cells and sometimes inhibiting them. For example, it can activate monocytes and macrophages through the toll-like receptors. Here I have TLR4, and with its interaction with this receptor activated these cells and phagocytosis. It can also inhibits the cells. For example, uromodulin can inhibit neutrophils by its interaction with receptor cyclic 9. Additionally, it interacts with scavenger receptors involved in clearing cell debris. Uromodulin plays an important role in maintaining ionic balance, which we named homeostasis. It reacts with specific types of kinases, and by them with membrane channels and transporters such as NKCC2, promoting their phosphorylation and stability. NKCC2 normally transports sodium, potassium, and chloride ions in 1:1:2 ratio into the cells, using energy from ATPase. By stabilizing NKCC2, uromodulin enhances ion reabsorption, forming a feedback loop with with TNF-alpha, which inhibits this process. Uromodulin also affects ROMK channels, influencing potassium transport. But homeostasis is a very complex mechanism, and uromodulin is only one small part. As you can see, uromodulin is involved in many vital physiological processes. For us as clinical biochemists, it's particularly interesting as a potential marker of kidney function. Reduced uromodulin levels increase susceptibility to urinary tract in infection, while excessive production could raise sodium reabsorption, potentially contributing to hypertension. And genetic variations in its structure can also be linked to disease. Pathologically, most uromodulin issues stem from genetic mutations. Mutations in its gene can use misfolding and accumulation in the plasmatic reticulum, triggering stress responses and, if severe, apoptosis. This mechanism underlies certain kidney disease, such as medullary cystic kidney disease. Defects in post-translational modification, such as faulty glycosylation or sialylation, can also disrupt its structure and function, increasing infection risk or destabilizing the protein. Finally, let's highlight uromodulin's use as biomarker of kidney function. Its concentration reflects nephron integrity and clinical kidney disease prognosis, for example. Our experiments confirmed correlation with other markers such as GFR, glomerular filtration rate, and cystatin cell levels. Unlike those markers, however, uromodulin is produced directly in the kidneys and reflecting tubular function without the need for complex equation or adjustment. In conclusion, uromodulin holds great potential in clinical biochemistry. As we've seen, it participates in numerous physiological and pathological processes, even though it may appear to be a waste molecule. We should respect its importance and continue exploring its potential. So this is all from me. Thank you for your attention, and let me now hand over to Professor Fridetsky.
Okay, hello everyone. At this presentation, we will look at the experimental parts of our study and on the results what we saw on two parts of this project. The first one was focused on comparison of uromodulin serum levels on a cohort called healthy, but it's generally without CKD. You can see 127 samples, or healthy person, and we compared it with CKD patients with different stages of this disorder. And on the left side, you can see very interesting separation or differentiation of these two groups. And it's just general look at this importance of this potential biomarker for diagnosing of this disease. We established something like cutoffs. Cutoff it's here, I'm sorry. But we can look at the median for patients, it's 79, and for healthy controls, it's 250 nanograms per liter. So there are strong differences between these two groups. And when we try to calculate and to construct ROC curves, you can see really excellent area under the curve close to 1.0. So it's accurately 0.97, I'm sorry. Now, what is really interesting is sensitivity is going really close to 100% with really good specificity. It's about 85%, but as you know, we can change it and adjust what we need. Yeah. So we conclude this the first stage of this study. It's really promising, and we continue with the first with correlation analysis, when you can see really interesting, not so perfect correlation of uromodulin with common biomarkers like EGFR or cystatin C. There is a positive correlation. It's so-called not strong, but it's a little bit below strong, like a middle correlation. And a similar situation is also in cystatin C, 0.76. Sorry, 0.62. I'm sorry. Yeah. What does it mean? Is that we can expect different mechanism of relation between the uromodulin and general kidney functions. And I think it's a really good image that it's located in tubular cells, and it's not fully compatible with this common biomarker. So I think it's really useful and promising. We can look at these correlations more deeply, and we can see not linear, but not so bad correlation with the EGFR, sorry. And with cystatin C, it's more complicated. We also look at the correlation with the urinary markers, and there's close to zero correlation in these two, like proteinuria and albuminuria. Yeah, and now I will go to the second part of the study, and we differentiated patients to 5 different stages of CKD, from 1 to 5, and to look if we can see the differences between the levels of this uromodulin in serum, and you can see really nice decrease of this biomarker based on severity of CKD from no mild up to most severe clinical presentation of this kidney damage. So we tried also to construct ROC for these 5 different stages, and you can see even for CKD stage 2, it is really good 0.1801, or finally 81% of accurate results for this stage. And if we will go more deep to stage 3, 4, 5, it's close to excellent biomarker in the point of view of statistics. The final slide is about if the uromodulin is dependent on sex or not. And we can see on this figure, on this picture, if we'll compare, for example, a stage 1 for females and males, there are no differences, and the similar situations are also for the other stages up to 5th stage. So it's not complicating like a parameter for uromodulin in future. Yeah, so this is all from my side. It was just summarization of the results, and I hope the next presentation, which will be also just a short, but we will show you 2 cases where we can see really good potential in clinics and in diagnosing.
So now I would like to show you 2 case studies of our patients that we examine here. First is 21-year-old male with Alport syndrome. Alport syndrome is a genetic disorder. There is an abnormality of gene that codes type 4 collagen. This syndrome is X chromosome linked in 80% of cases, and males are more affected or more severely affected. Primarily, kidneys, ears, and eyes are affected. Kidneys leading to renal failure, ears to hearing loss, and eyes to some ocular abnormalities. There is no curative treatment for this syndrome. We only aim for slowing down the renal dysfunction progression and symptomatic therapy. This patient at the presentation had CKD stage 5. He had complications of CKD such as secondary arterial hypertension, growth retardation, renal osteodystrophy, and anemia. Since 2021, he needed peritoneal dialysis. Unfortunately, this was complicated with recurrent peritonitis. So since 2023, he was on hemodialysis program. He needed 3 sessions per week. Each session took 4 hours. For this patient, there was an offer for first kidney transplantation from a deceased donor. Cross-match was negative, so offer was accepted. On December 12th, the kidney was transplanted. Immediate postoperative course was okay. As you see here, the uromodulin concentrations goes up. The renal graft started to function. The sonographic findings were satisfactory. As to the urine output, it was abundant. Unfortunately, on December 24th, patient started to feel unwell. He was nauseous, vomiting, tachycardic. Control CT found pseudoaneurysm on arterial anastomosis of the graft, and there was retroperitoneal hematoma, so he needed acute surgery. He needed multiple blood transfusions, so it occurred somewhere here. After that, he was stabilized. He unfortunately suffered acute kidney injury, and his ultrasound findings started to be less favorable. There was graft edema. The perfusion of graft started to be slightly reduced. Those are markers of potential graft rejection. Here from January the 2nd, he had multiple sonographic controls with still worsening sonography findings, and we see that uromodulin here nicely correlates to the sonographic findings. The graft was declining in function, and uromodulin also decreases in concentration. As to the glomerular filtration here, this patient, because of acute kidney injury and renal dysfunction, he suffered from complications such as we mentioned in the presentation before. He had fluid overload, he has pulmonary congestion, he had pericardial effusions, he had secondary pneumonia in terrain of pulmonary congestion. So that's why he needed hemodialysis. With this treatment and immunosuppressions, he started to get better. The graft function also improved. What we see here, glomerular filtration went up. The uromodulin also increased. Unfortunately, after some times, there again was ultrasonographic markers of graft edema. The antibodies were anti-DQ2 antibodies were highly positive, so there was second rejection. He was administered anti-rejection therapy, and we see that with again findings, ultrasonographic findings of graft rejection, uromodulin concentration also decreased, and after starting of treatment, slowly but surely his kidney functions and graft function started to increase again. The third case is 35-year-old woman with cystic fibrosis. She already had undergone a bilateral lung transplantation in 2015. Unfortunately, she had a complicated post-operative period. She had multiple infections, she had rejection, she had organ complications, and she developed chronic kidney disease grade 4. The etiology was a combination of contrast-induced nephropathy and diabetic nephropathy. And in this CKD, she had recurrent episodes of uremic syndrome. She needed hemodialysis, and she was put to waiting list for kidney transplantation. And as for the lung function, she was planned to undergo second lung transplantation after kidney transplantation. As I mentioned, she needed hemodialysis a few times a week, and here we see that after hemodialysis, glomerular filtration rate always goes up, increases, but that's because hemodialysis is meant to remove waste products from bloodstream, and one of those products is creatinine. So creatinine after hemodialysis is falsely lower than would be without hemodialysis. That's why glomerular filtration rate appears to be normal. But as we see in uromodulin, which is bigger molecule and it's not freely dialysable, that he was not removed by dialysis, and he still has shown constant and pretty accurate levels that estimate kidney tissue condition. So we can say that from these findings that uromodulin is reliable dialysis independent biomarker, by which here we can look at residual renal parenchymal integrity and tubular function. And to conclude, uromodulin is predominantly associated with tubular compartment of kidneys. There is potential to use him in diagnosis and monitoring of tubulopathies. He might be useful in kidney transplantations to predict and monitor graft rejections. Glomerular filtration and albuminuria is still used for screening, diagnosis, and grading of CKD, but uromodulin may serve as supplementary biomarker of kidney function. Might help in early diagnosis of chronic kidney disease, which is very important, as we heard today, for early and targeted treatment, and might be helpful in detection of kidney function decline. Thank you very much for your attention.
Great. Thank you very much, all of you. It was very professional information for us. We appreciate your time and your input. So I would like to ask if there are any questions. I don't see any questions, so maybe I will just try to ask for myself, the professor, that what he suggests as the best to include a marker uromodulin as quick as possible to routine diagnostic.
That's a good question. Thank you. I think we have to start to inform clinicians and to discuss with them about the possibilities, how this biomarker could be, and we hope it is promising and to be more accurate in these specific conditions. I cannot expect that it will be like a general biomarker instead of creatinine or cystatin C, and I think it's not the aim of this biomarker. But what we will see in future is the question. Maybe we will find it's even better compared to these common biomarkers. So the first part, of course, to inform clinicians. The second part will be, but it's specific for Czech Republic, maybe similar in other countries, will be to discuss with Minister of Health, with insurance companies to cover it, to pay for laboratories expenses. So I think these 2 stages will be necessary to do that. Maybe if you have any additional thinking.
No, I have maybe the education of clinicians and making sure they understand the possibilities of this marker and difference and the way how it looks at different functions of kidney. That might be helpful.
Thank you. Thank you for your answer. So there are no questions. So on behalf of our company, I would like to thank you for your time, for your preparation. It was very valuable for all of us. And for our partners, customers, we would like to just emphasize that we have available Clear Kit Uromodulin ready to use. So in the case you are interested in, just do not hesitate to reach out of us and ask for free trial. And I believe that we don't meet at the last webinar. So thank you for your time. Thank you for your attention, and we enjoy together, and see you next time. Thank you very much. And again, I apologize for technical issue, but for sure we will send a record from this meeting in separate email, so you can expect that there will be record. Thank you very much, and bye.
Thank you to you from Olomouc, and many greetings. Bye.
Thank you.
Hey.
Biovendor Group, bridging science and diagnostics.